Well, hello, everybody who is taking the time. We're super excited to have you join us. I'm Barbara Brill. I'm the president of the SCORE Charlotte chapter. So welcome. We're really excited to offer this webinar this evening called Employee Healthcare Benefits Simplified. It's an important topic for business owners. And so we're excited, as I said, to bring it to you. If you'd like to go ahead and start putting, we'd love to, know something about everybody. If you would be so well and kind to put maybe your name, where you're from, what kind of business you own in the chat box. We can start doing some shout outs. And then also, as we're going through the presentation, if you want to put your questions in the Q&A box, that will be terrific. So we'll start in just another minute as people are joining. Hello, Aisha from Nevada. Wow, super. Welcome, welcome. And Suzanne from Charlotte, right in the Dilworth neighborhood. Hello, Suzanne. For those of you who may not know much about SCORE, hopefully you all do. SCORE is a national organization, nonprofit, with over 1,500 communities. We have over 10,000 mentors across the country. And our aim, our mission is to provide mentoring and education services for people who want to start up a business or small businesses. That is where we put all our energy and time with all the volunteers that we have. If you don't currently have a SCORE mentor, and having a mentor is so valuable to any business, our mentorship is free to you, and the SCORE website, score.org, has tons of webinars and templates to help you with your business on just a whole huge range of topics. So please, if you don't have a SCORE mentor, go to score.org, put in your zip code, and you can ask to have a mentor, and you'll be in touch with the local chapter for you. So we're excited to have you here, and we'd love for you to be part of the SCORE mentee team as well. And maybe some of you even want to be a SCORE mentor, and you can find out more information about that at score.org as well. So let's see who we have Salem from San Antonio, Texas, Terrence from Waxhaw, North Carolina. And let's see where else. Another one from Waxhaw, Cynthia, who lives in Sarasota, used to live in Charlotte, who's starting a HR consulting firm. Well, perfect webinar for you, Cynthia. Well, we're going to go ahead and start. I am going to turn the controls over to my co-mentee, not mentee, mentor with SCORE Charlotte, Leslie Billow, who has a very strong track record and years of experience as an HR executive. So Leslie, it's in your capable hands now.
All right, thank you so much. So before I get started, I did want to take a moment to introduce our presenters today. You'll see, if you're looking at the video, McLean Goodwin, who's with UPG. So McLean is an experienced professional in the insurance industry with over 16 years of experience supporting businesses. And he currently works with United Producers Group as their Vice President of Sales. In addition, we have Cristy Gupton, who is the president of Custom Benefit Solutions. Cristy is a healthcare strategist specializing in employer-built healthcare plans, and these programs are focused on the direct primary care model as the foundation for their success. Cristy's bringing 25 years of experience in the benefits and insurance industries. So welcome to both of them for this presentation. And as Barbara mentioned, I'm a certified SCORE mentor, but what I bring to the table is a number of years of experience as an HR executive. So this topic is very near and dear to my heart, as it probably is to the rest of you, or you would not have signed up for this program. So before we jump into the main presentation, I just wanted to give a quick overview of what we were planning to discuss today. So I'm going to take just a moment to share with you some reasons why this is important. And then we're going to jump into the meat of the program, which is just to review benefit plan options for small businesses. And we're going to touch on several different types, including traditional small group plans, ICRA plans, professional employer organizations, and the direct primary care model. Throughout the discussion, we're going to have some Q&A. I will be moderating that. So as moderator, I'm going to be choosing some questions to share with McLean and Cristy. Some of them are prepared, but we'd also love to hear from you guys in the audience if you've got some specific questions for our presenters, and I'll do my best to work those into the program. And presenters, if you happen to see one pop up that you want to jump on because it's coming up, feel free to do that as well. But I will do my best to get to as many questions as we can. We do have the chat open, but there's also a Q&A section that we'll be monitoring, so I can watch that and pull some of those questions as they come up. So if you could please put questions that you might have in the Q&A so that I can monitor those. And without any further ado, I'm going to just jump into the first piece, which is why it's important. So a quick word on this. I think none of you would be here if you didn't see this as an important thing to focus on. But one of the main reasons a lot of businesses consider having healthcare benefits is because they want to attract and retain talented people. 80% of workers would choose a job with more benefits over a 30% raise without benefits. So these types of things are what gets that talent to come and work with you. And many people would consider leaving you if you don't offer these types of things. But beyond that, we also want to consider the health of our employees. Employees with healthcare benefits are more likely to seek medical attention quickly or to manage health conditions that they might have. And when they do that, they're healthy, probably happier. And one of the side effects for that as a business owner is you're going to see reduced absenteeism. These employees are probably going to spend less time out for themselves and probably less time out with their family members if they're receiving regular health care. So these are some of the basic reasons why this is so important for business owners to consider. One other thing I wanted to mention, because employee benefits does go beyond healthcare. It can include things like paid time off, like vacation, holidays and sick time, flexible work schedules, 401k or pension contributions, as well as many other things like discount programs, etc. But today's presentation is going to focus on healthcare benefit options only. So with that, I am going to hand things over to McLean. McLean, I will just need you to tell me when you are ready to move on to a next slide, but I'll try and monitor that for you, okay?
Yeah, no problem. And I just looked at the Q&A and there's a lot of stuff in there already. So we can touch on some of those as we go through that. But really what this first slide is looking at is we're just looking at small group plans. And typically we're going to see small group plans from an employer that employs 2 people up to 50 employees. These are normally going to run through some of your larger national health carriers, your Aetna, your Blue Cross, your United Healthcares. Most of these plans, you'll have a couple in there that might have a smaller network, but most of them are going to have your large national networks. And I saw there was a question in the Q&A about making sure that, if you've got employees, spread out all over the country, how do you ensure that they have an adequate network? For the most part, you would have to know where your employees are going to be and be looking at who the carriers you're choosing are to make sure that their networks are adequate across the country. Unfortunately, you've got United Healthcare's in another fight with someone with Prisma out of South Carolina, which is one of the largest health systems down there. And you have networks, insurance companies and hospital systems getting contract negotiations all the time. So it's tough to tell from day to day who's going to be in, but most of those things are solved fairly quickly. But when we look at the small group plans, you go with one of these national carriers, you're typically going to pick 1, 2, maybe 3 plans to offer your employees. You're going to base your contribution that you as the employer is that you're going to provide off of that from a company standpoint. And then you're going to offer those employees those benefits. It's not going to matter what state they reside in. It's going to be based out of where your company is located. Again, they're going to have a national network. And when we look at the 2 to 50, when we look at what we call the ACA, those are rates that are filed with the government on a quarterly basis, and you're locked into the same rate for a full year, and then you get a renewal.
Clayton, can you clarify, ACA might not be a familiar term to some people, so Affordable Care Act, and
Yep,
who does
affordable.
who does that apply to?
Yep. So basically, all the 2 to 50 business, when we look at what we call fully insured, which we can talk about that, but we might be getting in the weeds there. Those rates, they're filed with the government. It doesn't matter what the health of your employees are. If you were putting a health plan in probably 10 years ago, you'd have to fill out individual applications for the employees. You don't have to do that now. All we need is a census that has where your company's located and the age of each employee, and we're going to be able to produce a quote. Typically, that's going to be a little bit higher than some plans that will take into your employee's actual health into consideration. But they're all guaranteed issue. There's no pre-existing conditions, and that's primarily what we see, especially smaller groups when they're starting out. 2, 3, 4 employees. We're seeing them go into that market, and that's where they kind of dip their toe into putting an employee benefits program into place. But you've got fully insured. We're starting to see more level funded plans. That's where it takes into account, your employees' health. They can do that a couple of different ways. But really, who we're seeing take a small group plan, the smaller groups, it's easy to administer, especially if you have employees all over spread amongst different states. The small group plan is something that's going to be a good fit for you because it's going to be easy to administer.
Great. Ready to move to the next one?
Yeah, are there any questions on that, or you got anything, Leslie?
Specifically for this, no. So I'm going to suggest we just move to the next slide in your presentation.
Yeah, so an ICRA, we've seen this come, really the last 2 or 3 years become more prevalent. And what it is we've had employers in the past that have given an employee a stipend or their employees a stipend, a couple $100 to go out to the exchange and get health insurance. So the way that would work is there would be no tax deduction for the employer. So a number of years ago, some legislation went into place that allowed you to do an ICRA, and it's a health reimbursement account. So the employer, through this health reimbursement account, is allowed to give the employees a set amount of money, and then you have agents that will help them go out to the exchange and find the plans that are right for them. So if you have a younger person that wants a $5,000 deductible plan, they're able to go do that with the carrier of their choice. We have TPAs that help you, third-party administrators that help you choose, help the employees choose the right plans, set up the billing, and it allows the small group to give more choice to their employees and help contain costs because they're just going to be able to give them just a set amount. So we've started to see that become more and more prevalent, especially with the smaller group as they're starting out health plans. And maybe participation is an issue with them. The one thing that we do need to mention for all the individual markets, they are state-based. It's very rare. I think South Carolina has 4 plans. I'm not sure that North Carolina has a plan right now, but when you go on an individual plan, you must seek treatment in that state. So if you were in North Carolina and you went into South Carolina, that would be considered out of network. So that is one restriction when we start looking at ICRA plans.
Okay, so just to clarify, an ICRA is state by state, and that would kind of applying to Aisha's question about people in multiple locations might not work well for an organization that has people all over the United States. I do want to touch on, there's a question from Salim. He's asking about whether or not an employer would pay a fixed amount to each employee, and he's calling it a premium, and what if the premium is less than what's paid? But kind of maybe explain to everyone, what does this mean? Is it the same amount that an employer would give to everyone, or just set up the account. So maybe, can you address that question a little
Yeah,
bit?
typically in the smaller group space, the under 50 space where you're not having to meet affordability and you're not having to worry about any of the ACA mandates, you are going to give a set amount. So you're going to you give $200 a set amount. One of the qualifications is they have to use that for health insurance. So that's where the TPA comes into play. So if you're giving someone $200 and they find a health premium that's less than that, then that would be a situation where the TPA would help administer it and you would only be paying for the cost of their coverage. You wouldn't be paying in excess of it.
Okay. And another question that comes to mind that others might not be asking about is, if I wanted to pursue an ICRA, what's the best way to get started? How do you find someone to help you set one of these up?
A couple of years ago, there were a handful of folks, but now we probably have 20 of them calling us a day. If you have any questions, we can get you in front of a couple TPAs that is what they do, is they administer the ICRA plans, and we can have a quick conversation and get you in the right place as far as the complexity, how many different locations you have, because it can be a fit if you have employees in different states. It just adds a layer of complexity when setting it up. So that would be something that please feel free to reach out and we can get you in contact with the right TPA that would be a good fit for you.
And a question has come through. I'm answering what is a TPA? It's a third-party administrator, but who pays for the third-party administrator's services?
That would be included in the group price, so the group would be paying for that.
Okay. One other question before we move on from this section, because I'm also mindful of time to keep things moving, but if an LLC has only one employee, can they take advantage of something like this?
If you have an LLC, you wouldn't be able to, with one employee, you would not be able to set up the group plan. I would need to check, and I'll do that as a takeaway on whether you could set up an ICRA plan and run that through. I don't think you can, but Cristy's shaking her head no, and I think she's got a little more experience with some of these. But I do not believe with an LLC you'd be able to do that.
Okay. So, and your program, I know in the slide prior, it was employees groups from 2 to 50. So you got to have at least one more to do something like this. And would a husband and wife qualify for a group plan?
You would normally need one unrelated W-2 employee.
It depends on ownership too. So health reimbursement arrangements are generally not available to owners of the organization if there's an ownership established, and I think the only exception to that is maybe an S corp. So
Yeah.
hey, McLean and I are neither accountants nor attorneys, so we we know what we know, but you probably also need some advice from a professional like that too.
Yeah, then being set up, Cristy, I'm pretty sure that being set up as an S corp is the big thing that would change that.
And tell me this, if I felt like, okay, this ICRA you're talking about sounds like a lot of work, and maybe I don't want to get that deeply involved in planning something. You mentioned at the beginning that some people just give a monthly stipend. And I know that one of the downsides could be that if you give a stipend, you really don't know how they're using it. They could go out and buy groceries with it, not healthcare. And that would be the intention if you gave a stipend. But is there anything to stop an employer from just giving an allowance to every employee, same amount to everybody, if they wanted to just keep it simple in administration and then wait till another stage of their business to set something like this up?
Yeah, and we see plenty of people do that. I mean, you lose out on some of the tax benefits, and of course, you are giving the money to the employees, and you don't know exactly where that's going. It could be going for insurance. It could not be. But yeah, there's nothing to stop you from doing that.
Okay. All right. Anything else on this one, McLean, before I move to the next slide?
No, I think we're good.
Okay.
So the last one we have here is a PEO, or professional employer organization. So what we'll see a lot of startup companies, smaller companies use a PEO for is they outsource their HR. They can do any number of HR functions. They can run payroll. They can help you with employee benefits. They can help you with the commercial benefits. There are probably 100 of them out there that you can go to. What you do gain, if you're looking at them from an employee benefits perspective, is that most of them are going to have a health plan that's just for the members of their PEO. So if you're 2 employees, you're getting the buying power of, 1,000 plus employees, depending on how they have it segmented. The one downside of it is it does come with a fee in addition to everything else, and then the cost of everything else. You are going to be paying an administrative fee to them. But I did see, some compliance questions about, remote employees and things like that. A PEO would be a great resource because they would be making sure if you had employees in New Jersey or you had employees in California that you're setting up any state disabilities or anything like that to keep you in compliance if you do have employees in multiple different states. So that's what a PEO is. They're actually brokers out there that all they do is work in PEO. So if you feel like that's a fit for you, we've got people we can put you in touch with and ask a couple of questions and know that if your business is in this stage or these are your needs, that these are the 3 or 4 PEOs that would make sense to you. So if you think that's worth having a conversation, then by all means we can set that up for you.
And a question same as what I asked before. If I wanted to find an appropriate PEO, it sounds like contacting a broker could be one option for finding one. But are there other avenues for someone just looking to find a professional employer organization to do business with?
Yeah, I mean, you can go through a PEO broker, or you can go direct to, Insperity, ADP, Total Source, Paychex has one. There are tons of them out there. The one thing I would say about going through a PEO broker, which by the way, we're not a PEO broker, we just know some of them. They have access to a bunch of things and know the right questions to set you up in something that you really is really going to help your business and help scale your business. Versus if you go directly to a PEO, they're going to tell you exactly what they do well. And might not necessarily ask the right questions to make sure you're getting what you need.
Okay. And I know that we're at the bottom of your segment of this, but as I think about these 3 different options, how would an organization determine which of these would be the best for them?
I think it would make sense to engage with a broker and see where it comes out as far as what the cost is going to be and what your needs are going to be. We're actively looking with employers that we work with between these 3 options. Let's all be honest, at the end of the day, it comes down to, where can I spend the least amount of money and get the best amount of coverage and service for my dollar. So engaging with a professional to help walk you through these pieces would be the best advice that I could give.
Right. And one more question before we move on to Cristy's section. The PEOs, Aisha is asking if they help with international employees, and my belief, because I have worked with PEOs that do this, is you can find international organizations that can provide that same support in different countries.
Correct. I mean, that would be the best bet, is to get with a PEO that does have an arm that could help with that. As a rule of thumb, if you have employees that are traveling back and forth, it's going to cover, your state-based benefits are going to cover emergencies only, anything that's domiciled in the U.S. There are other avenues to get travel insurance, but then if you have a set of employees over there, the PEO could definitely help making sure everything is buttoned up over there.
Okay. All right. With that, I'm going to move on to Cristy to talk about direct primary care centric health plans. Yes. You'll have to cue me, Cristy, because you've got some builds in yours, so I'll do my best.
Okay, no problem. First of all, I just want to say thank you for having me. I appreciate being asked to be here. And so I'm excited to talk about how direct primary care and the plans that you can situate around that type of primary care works for especially small employers. So here's a good comparison between direct primary care, which isn't necessarily a new concept, but it is sort of coming back into fashion as the healthcare system gets more and more complex. The bigs, as I call them, big insurance, big pharma, big brokerages, big hospitals, as all of that becomes more and more vertically integrated, many primary care physicians have felt that the quadruple aim that a lot of us aim to achieve, and that would be quality care, low cost, better outcomes. A lot of people call those three the triple aim, but the physician experience shouldn't be lost in that. So if you add one more aim, you get the quadruple aim, right? And when the physician experience is important, and we should all feel that it is, we don't want necessarily to go to a doctor that is overworked, underpaid, stressed out, can't spend enough time with us. So achieving that quadruple aim means, in essence, changing the way primary care doctors operate and also how they're paid. So the direct primary care model embraces a cash-based monthly membership fee, as opposed to third-party reimbursements from insurance companies or third-party payers of any different kind. So in the direct primary care model, instead of a patient calling in and trying to get an appointment and being told that, you know, there's a waiting list of something like 21 days. That is the national average, by the way, for even an established patient to get in with their primary care doctor. So instead of having to deal with that nonsense, and then also having to wait in a waiting room and wait in an exam room, and then have only about 7 minutes, that's also a national average, 7 minutes with a doctor. Many primary care doctors have sort of left that system, opened up, hung a shingle, and decided that they're going to take care of their patients in a different way. And so the monthly membership fee basically already pays for every primary care encounter, including some in-office services like labs and prescriptions that can be dispensed in-house, and your basic suturing and chronic disease and wellness care and preventive care, and, you know, just lots of other things that primary care doctors are trained to do, as opposed to the traditional primary care model where, like I described just a minute ago, there's so much volume and on that side of the medical system, we really just get sort of put into what I call assembly line medicine as opposed to relationship medicine. So I truly believe that direct primary care brings back relationship-based medicine where doctors and patients have time on their side. That's really the biggest difference. Primary care doctors are so highly trained, but not even the smartest, most specialized primary care doctor can provide the best care in a 7-minute time frame. So giving back time for the doctor and the patient to spend with each other is probably the biggest difference in direct primary care. And the way they achieve that is really by not participating in the traditional insurance system so that they don't have to rely on a third-party payment mechanism to be reimbursed for their encounters with their patients. Okay, next slide.
I'm going to build part of this. Should I go on your cue or build a portion of this?
Go ahead and build that side. So I came up with a couple of scenarios where using direct primary care in combination with an ICHRA, like McLean talked about, and health sharing, is one option, and then go ahead and build the other side using direct primary care plus a self-funded plan, plus a flexible spending account. So I think these are solid options. I know that in some circles, health sharing probably, it could have a bad reputation. I will definitely tell you that I took about a year to vet all of the health shares I could get my hands on, and really only a couple of them met my criteria. So they're definitely not created equal.
Cristy, can you maybe give a brief explanation of what a health share is? Because I don't think the audience is that familiar with that.
No problem. So I would say after the Affordable Care Act, it came more into fashion, especially once certain groups of people started to say that, well, the Affordable Care Act options don't necessarily fit with my personal philosophy or my, moral or religious philosophy. And so some of the health sharing, the religious-based ones, started to pop up and say, well, we can create a community of those who think like us or believers or whatever, and we can create risk sharing, risk pooling, but without insurance company, requirements. And so they did that. And like I said, they're not all created equal. You really need to dig into the details. And I did that. A good piece of advice for everyone out there is to definitely find a good advisor to make sure that you're asking lots and lots and lots of questions. But from a direct primary care, including that ICRA that McLean talked about, that helps you satisfy the minimum essential coverage mandate. So if you do have more than 50 employees and you are required by the Affordable Care Act to have a plan, it doesn't necessarily say you have to have insurance. It just says you have to have a plan. So one of your plans could be this trifecta between direct primary care, the ICRA, and the health sharing. And that ICRA, since it gives your employees, especially that might have pre-existing conditions, it gives them employer money to go out to the individual marketplace and purchase an individual coverage. That's what the IC stands for in ICRA, individual coverage health reimbursement arrangement. So you have a safe harbor in that strategy for employees that do have pre-existing conditions, but for everyone else who might like the idea of health sharing and like the small, financial commitment that it takes to be part of those communities, that's a solid strategy, and it's being deployed more and more every day.
Cristy, a quick question that popped up is, does a DPC qualify as health insurance for tax filing purposes?
Not alone, it doesn't. So I would say that the implementation of the ICRA inside a strategy like that, it does give the employer the box that they can check that box that they have satisfied minimum essential coverage, and that essentially gets them off the hook from the employer mandate. Now, remember, since a health reimbursement arrangement is a qualified account-based reimbursement strategy under Section 105 of the Internal Revenue Code, the money that employers put into the health reimbursement arrangement is tax-free to the employees that reimburse themselves out of that account, as well as tax-free to the employer that contributes the money into the HRA. So health sharing, I think there's not enough information from the IRS for us to make a determination on that. So to err on the side of caution, we should not try to get, free tax or no tax on health sharing contributions. But direct primary care is considered a Section 213D eligible expense under like flexible spending account arrangements, and hopefully, fingers crossed, soon to be eligible under a health savings account modality. So we're kind of waiting on a bill that's cycling its way through Congress right now to help connect the dots between direct primary care and health savings accounts. But right now it's a valid, eligible, reimbursable expense through an HRA and an FSA. Okay, moving on to direct primary care plus a self-funded plan.
Oh, sorry.
It's okay. I'll just touch on this real quick. Self-funded plans also have rules around meeting minimum essential coverage. And so if you're working with your advisor, they know exactly how to make sure that you're structuring a self-funded plan the right way. And you've got the stop loss coverage to make sure anything that hits your plan that's catastrophic is covered. So I wouldn't be scared by the term self-funded. You're not out there all by yourself, so to speak, but it does give you a way to control, healthcare spending. It gives you more data, more knowledge and insight so that you can create programs that really work for your organization. And it is a full-blown health plan in all the respects that a fully insured plan would be. It's just that it's funded differently. And this would be great for small businesses who maybe have very positive cash flow, and they want to make sure they're spending smart money for healthcare instead of, being blind to where the money is going in their health plan. So I think that's probably enough on that slide.
Okay.
And why do we want to do this? Well, we're on a trend where healthcare costs are going up and up and up. They have been for the last decade. And this is just one report. PricewaterhouseCoopers is just one entity, actuarial firm or large consulting house that is predicting another 7% this year and into 2024. So I think employers are at a tipping point where they just can't sustain any more increases at renewal season because of the way healthcare is structured. We need to make sure that we're pulling back on some of that constant increase. At some point, we have to realize we're being priced out of the market, and we need to do something about it.
This is another build. You want me to build the whole thing or no?
Yeah, go ahead and click through that. So I thought I'd share my own personal experience. That way I don't get into any trouble with HIPAA, right? If I just talk about myself and I give myself permission to talk about myself, then that's fine. So before I joined the practice myself of a direct primary care doctor, I had been referred to an endocrinologist, and I just wanted you to see that not only what I paid on my own, that $75 copay that's in the yellow box, that's what I paid. Just that dollar amount is equivalent to the national average of 1 full month of unlimited primary care with a direct primary care doctor. Now, of course, based on geography, some DPC doctors around the country may charge more, may charge less, but that's the national average. Well, on my old health plan through my husband's employer, which was through one of the big insurers, the big health carriers, my copay to see this specialist was $75. So they also charged my husband's health insurance carrier $180 just for an office visit, $40 to check my blood glucose, $50 to check my A1C, and you're going to love this one, $11, the handling of a specimen from a doctor's office to a lab. Okay, let's just be honest. Every time you go in to see an endocrinologist, they make you pee in a cup. Okay, let's just get that out there. So I did. I put it in the little door in the wall, and they charged me $11 to pick it up on the other side of the wall. So the lab was in the doctor's office, but they still billed my husband's insurance company $11 just to pick it up out of the door they share a wall with the bathroom. So I'd show you that to tell you that all of those charges that tally up to $567 billed to the insurance, plus the $75 that I paid on my own in a copay, that's $642. I spent about 10 minutes with the doctor. That's roughly $65 a minute. So instead of paying for healthcare that way through an insurer, having affordable monthly membership where you're afforded unlimited primary care with a direct primary care doctor, where the encounter is already paid for, and instead of only getting 10 minutes of time with a physician, you really have unlimited time. So when I first started seeing the direct primary care doctor that I do see, when our relationship was new, we spent hours together. So I feel like this is the smartest way to spend money for small businesses, especially when employees could be in your organization, they could be avoiding care because they either don't know the cost, they don't know what their portion of the cost will be, they're afraid of surprise bills. And going about it this way in a transparent manner, where you're going ahead and paying for the encounter up front and it affords you unlimited care on a monthly basis, that may be the thing that your employees latch onto and say, gosh, why weren't we doing healthcare this way all along? So I just thought I'd show you my own personal experience there. So thanks for letting me talk through that.
Cristy, a couple of questions before we move from this slide. And I think you've partially answered some of them, but to be clear with regard to how things like labs and blood work or the urinalysis would be handled with your DPC, do most direct primary care doctors have some sort of an agreement with a lab if they don't do the testing themselves? Is the draw of the blood included? I mean, from your experience with various groups, is that how this sort of thing is handled? Because clearly it wouldn't just go away, but it may or may not be included in that $65 that you're talking about, or the monthly charge.
Sure. So I will say that one good thing about direct primary care is that most of these doctors are independent and they run their own small business. So they determine what they want to provide. But also sometimes one of the bad things about direct primary care is that they're all independent and you don't always know what they do and don't provide. So it's always good to just get out there and meet the doctors and ask your own questions. But in my experience, I know that most DPC doctors do one of two things. If they've got a nurse on staff and that nurse probably is very comfortable with doing blood draws and, pulling the blood into the little vials and wrapping them up, and having either LabCorp or Quest come and stop by once a day and pick all that up and take it to where it needs to be tested, they do that. Or what happens, like with my personal direct primary care doctor, he just sends an order to the local LabCorp or Quest office in my town, and I just stop by there and let them draw it, and he gets the results the same day. So it's easy, and they do have very significantly discounted lab fees. Like, for instance, on the screen, it shows I was billed $40, or my husband's insurance company was billed $40 just to check my blood glucose. That would be somewhere in the $1 to $2 range. Hemoglobin A1C might be somewhere in the $5 range. So they have deeply discounted arrangements with the national lab carriers, the lab providers.
Great. And in the interest of time, I want to throw out one more question, if you can answer it briefly, and then I want to complete your part of the presentation so that we can make sure we get to any other questions. One major question I would have is, clearly this isn't an ER. So if I were involved in a major accident and needed care beyond what a regular physician would offer me, what happens?
If you don't mind, just go back one slide, and let's just remember, I'm not pitching direct primary care in a vacuum. I'm pitching direct primary care in conjunction with other strategies like the health share or a self-funded health plan. So
Okay.
yes, direct primary care alone isn't going to serve all of your needs, but we're talking about it as part of an overall strategy.
Right. And I just wanted to make sure that point had a fine point on it because there was a question coming through and I wanted to make sure we were clear about that. It's great for the day-to-day and health management needs, but you need that combined suite of things that Cristy was talking about. One other question that came up was DPC. If you're covered through a DPC and you need a specialist, like if you have cancer, what happens? And very briefly, because we need to get to your last couple of slides too.
Sure. So just like any primary care physician would, they make referrals. And the good thing about direct primary care is they're sort of like your lens into the rest of the local care team. They have relationships with all the specialists in your area. And if you're part of a group self-funded health plan, there's usually tools and features built into a smart health plan, that gives you a lens into the national landscape for truly highly specialized specialists, you know, the kind of specialists who do their craft better than anyone else in the country. So it's really not altogether different than the way you're doing it now. I personally think it's way better because the misaligned incentives aren't there. If your primary care doctor is owned by a large hospital system, then they are required to refer you only into the hospital system family of ownership. So if you're with an independent primary care, like most direct primary cares are, then they are at will to refer you to who they consider to be the best, not just who they have to refer you to.
Okay, well, let me move us along so that I have a few open questions out there, but let's just move on to this slide.
Sure. So a lot of people wonder, well, yeah, hey, maybe I know of a direct primary care doctor in my town, but I have employees all over the country. So there's a couple places where you can find dots on a map that may help you identify where more direct primary care is in every zip code in America. So the DPC Alliance is one. I like that one a lot. The DPC Frontier. I go to that one second because they also put concierge medicine and hybrid direct primary care practices on their map. And so there's some, good physicians in that, but you just need to kind of know the differences between. And then the Hint Connect map is another DPC specific options, but they use also both physicians and mid-levels, nurse practitioners and physician's assistants that might practice in the DPC model. So a couple of resources there.
Okay, gonna move on. All right, so I'll give the disclaimer that we ran into some technical issues, not able to play this video, but Cristy, if you can give us like the thumbnail overview of what this has, and all of you participating can actually click on this and watch it. It's a 2-minute video.
Sure. So this is a Dr. Lee Gross, wonderful physician down in Northport, Florida. And he is a champion and a pioneer in the direct primary care movement, one of the first ones in the country. And he basically talks about restoring the doctor-patient relationship, putting patients back in the position of priority where they should be. He talks about how it frees him up to do more thorough work for his patients and to negotiate with other providers. He talks about negotiating a price of like $300 for an MRI with a local imaging center on behalf of his patients. So the gift of time is really what differentiates the direct primary care movement from the traditional setting. And so you can find this video on a website for a group that I belong to called Mitigate Partners. And this comes from the Mitigate Partners YouTube channel. You'll find many videos at mitigatepartners.com and on their YouTube channel. This is just one of them. It's one of my favorites, but it does give you about, I don't know, 2.5 minutes worth of commentary from a direct primary care doctor, one of the best.
Great. All right, so we've got about 10 minutes left, and I'm going to see if I can successfully get past that. Yeah, I can hear this video, but nobody else can. But what I wanted to do was maybe use the last 10 minutes to cover any remaining questions. I see a few in the feed that I haven't gotten to yet. So the first one I'm going to throw out to both McLean and Cristy is from Tyler Johnson. For a single member LLC, is an ACA marketplace plan the only option?
Yes, that's most likely going to be your only option.
So I'll go in the other direction with that. I am also a single member LLC, and I myself decided that I would go in the direction that I mentioned, a direct primary care with a health share. And I'm now 3 years into that arrangement, and I'm so happy with it that I could promise you I'm never going back to the old way.
Okay, here's another one I'm going to throw out to both of you because it kind of combines some things we were talking about earlier. So from Aisha, she wanted to know, can you combine different types and what I would say different approaches? Maybe an ICRA for your domestic employees and a PEO for your international employees?
So I'll take this first, and then I'm sure McLean has some answers on this too. Under the ICRA rules and regulations, you have 11 different class structures that you can class employees into. And so those could be a class of full-time, part-time, seasonal, those that, just have one niche over another. And so within your workforce, you can class employees into different classes. And as long as you're providing everyone in the same class, the same benefit, then you're fine. But if you've got international employees and they need to be in their own class, that's part of your, part of the resources under that law that you can utilize.
Yeah, no, I would agree, and then I'd say you'd have to dive into what exactly you need internationally. Like it's going to depend a lot on where they're located, how the company's set up, and that would be a more complex question, and probably more questions on this side than answers we've got right now.
So I am scrolling through the questions to see if, and I believe we have covered many of them. We actually had a few that came in. I've been monitoring the chat and the Q&A, and we had a number of questions from Aisha. A few of these I think we touched upon, and McLean and Cristy, I don't know if you've got your Q&A tab open, but maybe take a quick scan of that to see if there's any of that you can expand upon, because those questions popped in right as we started. And I think we touched upon a bit of this through both of your parts of the presentation. And in the meantime, we've got about 7 minutes of planned time left. So if anyone has an additional question that they want to either put into the chat or the Q&A, we can definitely try to get to it. But Cristy, McLean, any additional comments on some of the multiple tiered questions that Aisha put out in the Q&A?
I'd love to speak a little bit about telehealth. Certainly digital health companies are popping up left and right. I know about one that I really like a lot, where employees have nationwide in all 50 states access to a doctor within 15-minute turnaround of a call. But once the doctor and the employee determine what they need, if something next step is needed, like a diagnostic test or maybe an x-ray or an ultrasound or something like that, they can deploy a mobile unit, which is so interesting. So like a little SUV upfitted with diagnostic testing supplies and a mobile x-ray will show up wherever they are. Now, that's not in all 50 states, but it's in a growing section of the country. And so in telehealth, there is all kinds of innovations happening every day. So I would just say, what you really need is a good advisor and a little courage. That's one of my taglines. I think that it always takes courage to embrace change and look at new things. So as long as you have a good advisor and a little courage, you've got what you need.
Great. McLean, anything you want to comment on? Because as I scroll through it, I know that you touched on some of these, but I don't know if there was anything else you wanted to add. And I'm still monitoring for additional questions and haven't seen any new ones come in.
Yeah, I did not see anything on there that I didn't feel like we didn't touch on.
Okay, and there is a question from C. Bryant. As a small business owner, are we legally obligated to provide health solutions for employees? And I know you touched on that with the Affordable Care Act. That typically only applies to employers with 50 or more employees.
Correct. Until you have 50 or more full-time equivalents, if you have a lot of part-time folks that make up to, over 50 in the prior calendar year, that would be when the legality piece comes in. Up until then, it's more of a, what do you want to do? How do you recruit and retain employees and
keep them healthy, right?
Yeah.
As we touched on before, there are other reasons than the legal reasons why you might want to consider.
Correct.
And one additional question, and I see Barbara, you popped back on because we've got 4 minutes before we need to be cleared out. So from Lawrence Schaefer, so this was good info, not clear on how to figure out what the best option or set of options would be for my employees. What's the best way to proceed from here? And I'm going to just start with this because I don't want to put McLean or Cristy in a position where they're like, oh, call me. Really, the purpose of this was to give you all of these options to consider, but I would suggest evaluating from a cost and risk perspective what your business is prepared to do. Not knowing the size of your business, it's hard to say, but I would say that a nice first step for some employers is to just go about the business of setting up some funding mechanism so that people know that you're trying to support this because you may be too small to offer a plan. And Suzanne's asking, can we call Cristy or McLean? I'm sure that they would be more than happy to field your calls if you've got any questions. So that's why their information is on this final page as contact information if you need to reach out for any additional clarification on some of the things we've discussed today. So we're within the last couple minutes, Barbara, and I know some things have been popping up, but it seems like wrap-up questions.
Yeah.
So Barbara, I think we're ready to wrap up.
I agree. I think it's been very, very informative. Thank you, Cristy and McLean, and thank you, Leslie, for pulling this together. It was, very, as I said, very, very informative. And thank you, everybody, for attending from all around the country. That's very exciting for us. And please, if you're not working with a mentor in your city or your town, please go to score.org and, come and ask for a mentor. We're here to help you find the resources. We're not consultants. We don't do the work for you, but we can help point you in the direction of where you're going to be able to get the answers. So please feel free to become a SCORE mentee. We'd love to have you. And again, powerful webinar. Thank you all very much. And everybody have a great night.
Thank you so much.
Hey,
Bye-bye.
everyone.
Thanks, everybody.